Good morning, everybody. I hope you enjoyed yesterday's session, and we are very thankful for some of the feedbacks received. So, slight changes have been made in the program in response to your feedback. So, we will be having Breaking Bad News, but instead of the role play, we will be having the full outline of how to go about breaking bad news, because we felt that, yes, if you do not have the background, you may not appreciate the role play. Okay. So, and again, Jilly has volunteered to take you through that. So, thank you very much. Just, we are handing over to Jilly. By the way, while she is coming, from the audience, can you tell me what is bad news? What do you consider bad news? We say breaking bad news, but what is bad news? Quick. Unpleasant. You hear many unpleasant news every day. You know, you didn't get 99%, you got 95%. Or that today you didn't get the tickets for the flight, or the price of the tickets has gone up. Is that a very bad news? So what would you like to narrow it further for bad news? What is a bad news? Think. For a patient, okay, we are talking cancer, so what is a bad news? What is a bad news? That leads to stress. Yes, stress of a severe degree. But can you tell what stress? You have to give up something in life, maybe something unexpected that brings about changes which you are not prepared for. You know, when you are booking a flight ticket, you know prices may go up. You know that you may not get a ticket. But usually when we are talking of bad news, we are worrying that it may lead to changes in our lifestyle, what we were used to, and it may be something we never imagined. And all those things and its unpleasant connotations, and then what is the response of the person who cannot come to terms with it?
Okay, thank you. Do I need to welcome anybody from another place today? Is anybody else joining us today from Varanasi?
No.
Rims. Imphal. Are they here?
You can all ask questions from Imphal also, please.
Is this? Oh, Namaste, Imphal. Where's the camera?
Namaste,
we're getting it in my background. Namaste. Namaste, Imphal. Very pleased that you're with us, and please feel free to ask questions. Okay, the bad news is for you today that I am going to be talking again. Okay, it's great news for me to have you here, but what I really want is to have an interaction. It's really important. And I understand if there's some of the things yesterday that I may have said may need some more explanation. So when I teach, I try and mirror what you would be doing for a patient. So, would you be asking your patient, did you understand everything we discussed? So, did you guys, from my point of view, understand everything from yesterday, or are there any questions? Please, you've had overnight to think about it. Have you got any questions for me from yesterday? Or was everything as clear as mud? Any questions? Has anybody got any questions? In our marriage ceremonies in the United Kingdom, they say, is there any just cause or reason why these two people may not be married? Speak now, or forever hold your peace. So you have an opportunity. Please don't be afraid. I'm a simple diploma nurse. Not a professor or a doctor. I'm just a human being like you, but I happen to be a bit older. That's all. I'm just like you. My skin color is slightly different. My hair color is different. But basically, I'm the same as you. And I have come to share my knowledge of what I know, which is not a lot, but share my experiences so that you can learn from them. But I want to teach what you need and what you want. So you have to say, okay? And don't be afraid to ask questions as we go along, because that's the style of teaching that I really like. And normally, if I was teaching in a smaller group, although I can see all of you, I can sit to teach. Is that nice to be on eye level? So this is an example. When we're breaking bad news, we don't do it standing in a hospital corridor. So let's say that you are, how many social workers have we got here? 2. Okay, nurses? Great. Doctors? Super. Okay. So when we're breaking bad news, we don't do it standing up in the ward, in a clinic, or in a hospital corridor. Because what we have to do, and I'm going to be talking about this, we need to prepare people mentally for having bad news. Because it could be a shock. They may go to a hospital for an investigation, expecting everything to be fine, and actually it isn't. So we talk about a warning shot. So I'm going to explain this to you now. Right, now, this format, I will get this made into a handout for you, okay? And I will get my written slides made into, I'll pass those on to you, Professor Bhattacharya, and you can get them made, or you download them online, or I don't know what you do, I don't know how you, it's very clever, I don't know all that stuff. So these guidelines that I'm going to show you are simple and effective. They've been tried and tested. And they've been tried after research in India 24 years ago. And Dr. Bhattacharya worked with the author, Peter Kay. The great guy, because he came to Varanasi. Do you remember, Bob? Okay. So written as a result of coming to India, because the doctor realized, and I want to ask you, okay, so you have to give me bad news. In all reality, how long do you have for that consultation? Okay, hands up, 5 minutes. 10 minutes? Half an hour? 10 minutes? What about the rest of you? 1 hour? 2 hours? 3 hours? 10 minutes? 15 minutes? No time at all, because none of you are responding. How long, when you have to give somebody some bad news, how long do you have for that consultation? Professor Bhattacharya said 10 minutes. That's very realistic. I need you to interact. Can you understand my accent? Do they understand me, Bob? Is my English difficult? Probably is difficult. Do I have to be more dearie? Dearie? Okay. Okay, we're going to be talking about the quality of time. Quality, this is all simple stuff that you can do. Right. So, before you start doing the bad news or anything else, we have to greet the patient or the relatives. Doesn't have to be a big introduction like yesterday. We just do namaste. Namaste. Sure, I'm a social worker. My name is Sandra. I'm a nurse. My name is Professor Bhattacharya. Whatever it is, introduce yourself. That is the start. That is the start of creating a relationship. Because the God within me bows to the God within you. And immediately, so you're not just homing in on the person's disease, you're seeing that person as a human being. That is step one of breaking bad news. You have to introduce yourself. You don't just go in and say, I've got bad news. So let's just remember Gandhiji, that a patient is the most important person in our hospital. He's not dependent on us, we're dependent on him. He's not an interruption of our work, he's the purpose of it. He's not an outsider of our hospital, he's part of it. We are not doing him a favour by serving us. He is doing us a favour by allowing us the opportunity to do so. So, sitting, step one. And this is why I've got this stool here today as a symbol for you to sit. I'm sorry if your hospital authorities don't allow sitting. I think sometimes it's difficult for nurses, but I'm going to be working with people to change that outdated way of thinking. We have to sit when we're having a serious conversation with the patient. We're not talking about where are we going for a meal tonight. We're talking serious. And by the very act of sitting, what are you doing? Sorry? Go on. You're coming to their level, good. Your eye level, it's a good communication level. Also, you're probably, so you're not standing there saying, okay, where should we go for a meal tonight? Should we go to Deja Vu or shall we go to McDonald's? You could say that standing up. Right? You might say, we've booked at Deja Vu. I might say, oh, sit down, I've got some bad news for you. Deja Vu is shut today. Maybe. But that's, as Dr. Bhattacharya said earlier, it's not important. So you could say it standing up. But if it's something serious, you need to sit down. And that sitting is a warning shot.
Could I just add something? When we sit, we tell we are going to give you time. It immediately tells that we are not about to just talk to you and then I'm ready to go. We are there to listen to you. Then only may he think of opening up. If he feels that we don't have the time, with whom is he discussing? People who don't have time for him. Okay?
It's a very, very simple thing. Okay. So compassionate communication, remember compassionate, entering into the suffering, is the key to breaking bad news. Sit. 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 Eye contact. Sit by the bed. Sit. So this picture was taken in Cuttack when I was working with the doctor, Peter Kay, on, we were attending clinics. I think I probably told you this picture yesterday. Showed you rather. So Peter Kay was with me in the clinic. This man comes in and you can see a foul, solid head and neck tumour, which I know this is not a medical, you're social workers, you're not doctors, but you know, this is not going to be curable. It's incurable. But unfortunately, the patient had been lied to by the doctors. Unfortunately, The relatives had said, please don't tell him he's got cancer. So he wasn't told, but every day he was going to the cancer centre in Orissa, in Cuttack, travelling from further than Bhubaneswar, much further away than Bhubaneswar, where they had that terrible flood, where the tide came, tsunami came in. Like Balapur, is it, or Alipur, or... Anyway, it was a long way away. So he came travelling, and he was separated from his family. He came for chemotherapy. They sold part of the daughter's dowry, land, farming land, the cow. And I've heard of it, I don't know if it was yesterday or here or the last place I was, that somebody, a lovely lady in Silchar, sold their goat to pay for the daughter's treatment. So we have to be gentle with the truth. What happened with this patient was, I think I told you this yesterday, but it bears repetition. So the three people come into the room, two brothers and the patient, and the doctor looks and says, oh, fine, everything is good. To the patient, please, will you wait outside? What is that saying to the patient non-verbally? What does it say? Because do you know about non-verbal communication? So if I do this, am I interested in you? No. So non-verbally, asking the patient to wait outside, what is that saying to the patient? Well, partly you're not important, right? I want to talk to your brothers. You wait outside. What else is it saying? Am I going to give good news to the brothers or bad news? So you asking him to wait outside is actually saying to him, I'm going to talk about you, and what I have to say is bad news. So the guy sitting outside the room, of course he knows. The family...
Jilly, and the only thing he will not know is how bad it is. He can imagine anything. There is no limit to how bad the news can be.
So, it's a difficult one. But anyway, what I did do, I just said, when they told me the story about him coming to the hospital, being away from his family for days on end, spending all the money, all I said to the brothers was, does he have any daughters? So like yesterday's story about the man who was worried about his daughters getting married, suddenly, wow, and the penny, we say the rupee dropped, the penny dropped. That means, oh. And it was the brothers who said, so if he's not going to be cured, there's no point spending money on this treatment. Exactly, there's no point. If I'd been the brothers, I would have been so angry with the doctor that they'd allowed me to waste all this money. The only person that's getting rich are the drug companies and the doctors. It's ethical. So you don't have to be brutal in telling the truth, but I'm going to show you the way. So what happened in the end? They took this gentleman home. He had no further treatment, and he died at home with his family. So it's how we do things. And I think we have to be very, very careful. Your family system in India is absolutely amazing. But I'd like to ask you a question now. Okay? Imagine that you have a life-threatening illness. You've got 6 months to live, and I know it. I know, I'm the doctor. Would you want to know your diagnosis, yes or no? There's no wrong answers. Any no's? Because sometimes people say, no, I don't want to know. It's okay to say no. But would you like to know? Okay, so I'm your doctor. Your loving family come in and say to me, don't tell him, don't tell her. Then what? how are you going to feel? Why do you want to know? Why do you want to know? Why does it matter? Why shouldn't I lie to you and keep you happy? If I lie, will you be happy? Why do you want to know? There's no wrong answers. Why do you want to know? So you want to know what's happening, and you can prepare to fulfill your wishes. Now you're a lovely young girl. What would your wishes be? We've all got different wishes. Go on.
To travel the world and get a house for my mother.
Okay, great, to travel the world. Well, it could be that with good palliative care, even if you've got 6 months to live, you can say, okay, might not be able to get all round the world, but where can we get you to? Do you understand? So for me, it would be different. I don't have children. I don't have grandchildren. I have godchildren in different countries in the world. Probably if I knew I was dying, I'd want to come back to India. To die here. That's what I would want. If somebody lies to me, I'll end up dying in England, and I don't want to die there, I can tell you. So we need to have that choice, and if we lie to people, they have no choice. So we need to think about it. Who are we protecting? Who is our duty of care to? The patient or the relative? Exactly. So you need all your good communication skills to work with the relatives, because actually it makes your job much easier if the relatives say don't tell him. Much easier, because it is sad and it is difficult, and it does cause tears, and it causes an emotional reaction. So we have to think about how we deal with those emotional reactions. So, that should have gone up first. Why is it important to maintain trust? Trust has a word, it comes from the word truth, it's the same root. If I lie to you, if I said to you, actually, I'm a doctor, I will get copies of this, I promise. We need to get handouts. I promise I will make you handouts. You can write if you wish. If you don't want to, you needn't. To maintain trust. So if I said to you I was a doctor and I'd prescribed some chemotherapy because it looked good, and then you found out I was a nurse and I didn't know what I was doing, but I sounded good, what would you feel? Would you trust me again? No. So we have to try and maintain trust to reduce uncertainty. What's going on? So this poor man waiting in the corridor, what's going on with me? Am I getting better? Am I getting worse? And when people actually know, they can sort of prepare for that. It's like right now, I know Dr. Bhattacharya has just talked about air tickets, but actually I have a very busy schedule, and I'm probably travelling thousands and thousands and thousands of kilometres. And actually, I want to know if my train that comes into Delhi gets me in time to go and get a plane to somewhere else. I have to make sure. I need to reduce the uncertainty. There's no point saying, don't worry, madam, we will get you there. I want to know. To prevent inappropriate hope. Inappropriate. So you want to travel the world for 6 months, and if I say, yes, you'll be absolutely fine, and then actually your life expectancy is really 2 months, it's not helping you, to give you inappropriate hope. So we might say, well, look, I think 6 months is too long to travel the world. Are there parts of India you'd like to go to? So you still maintain hope. Would you like to go to a neighbouring country where you can come home if you don't feel so well? To allow adjustment, because it's a big shock. It's life-changing. and to prevent a conspiracy of silence. Now, social workers, this is really important. It's important for doctors and nurses. Do you know what we mean by a conspiracy of silence? Can somebody explain it to me? What's a conspiracy? Well, a conspiracy of silence might be that Dr. Bhattacharya and I know that you're not going to get lunch today. There's no food. We pretend that there is. You suspect that there's no food because you can't smell any. But, we know, but we lie to you. We all have an idea that there's not going to be any food today. But nobody talks about it openly. And if we said, actually, there won't be any food tomorrow, yesterday we said, there won't be food, you need to bring a packed lunch. Okay? We're open. You can prepare. So, this is important. Breaking bad news is important. Okay. Why is it difficult? What's difficult about breaking bad news? Or is it easy? Okay, there's no wrong answers. Have any of you ever broken bad news, had to break bad news? No? God, you're lucky. You've never ever had to break bad news. Dr. Bhattacharya, have we got the right people in this session? You must have an amazing job working in India with all the suffering that there is, and you never have to break bad news. Are you lying to the patients all the time then? Don't be afraid. Do you ever have to break it? Because otherwise I'm wasting my time giving this session. Why is it difficult? Or maybe it isn't difficult. Well done. We don't know the patient's condition. Okay. Why else for you personally might it be difficult? Yeah?
That becomes difficult for me as a doctor to explain to the patient or the relative what exactly is the problem. In India, most of the people still think that the surgery is the main treatment for any cancer. And they always ask, even in last stage, they ask me whether surgery is possible and you cannot remove it or not. So that understanding is quite difficult in many people. Even if you explain that it's already stage 4 and what we can do is mostly PAL, chemo or radiation therapy, it is not curable. They still has that hope at some point. And sometimes they don't understand actually what is the problem is exactly.
Okay, because they don't understand the words. So we are the professionals. It is my job to find a language, even if it's drawing. Now, lots of our top consultants, some of our best consultants in the UK, do pictures for the patients. They do pictures. So they might, you need to think of a creative picture. And you might do a picture, say, this is looks like your tumour, and this is what's happening, and this is where it's pressing, so we can't remove it. Because it's near an area that would be too serious to remove it. So we will try with radiotherapy, that should shrink it. We will give steroids. Chemotherapy, I don't know if things have changed, but certainly 25 years ago for head and neck cancer, chemotherapy wasn't the drug of choice, but obviously things change and maybe it is now. So I think we have to not hide behind jargon. Do you know what we mean by jargon? Talking oncology, carcinoma, all these things, people think, what does it mean? They tend to understand cancer. It's a difficult word for us to use. Patients understand that. Carry on.
Yeah, that's fine. I do sometimes draw the diagrams that where is the tumor situated and it has spread to the lung, liver sometimes. But some patients you do get where their understanding level is very down.
Of course.
So, and it's very difficult at that time to explain. Right? Yesterday I also had some patient with the same problem. and he must be like 8th or 9th standard studied only and nothing more. So it's very difficult to explain to them, and they still have that very high hope that if you get treatment here. The problem also is that some patients do get treatment in Nigrims, they get cured or they get well, they go back. Then they tell their relatives that you go to this hospital, probably something will be done. I got very well, now I'm doing my work and I'm cancer free. So that hope is also spread from the other people, but they don't understand that the type of cancer, what the other person has is different compared to what he or she has.
Okay, so thank you for that. And we have to find a simple way. So for instance, I might say, there is Indian curry. Curry. One word, but in your curry you may put coriander or you might not. You might put garlic, you might not. You might put onions in some, coconut in another. They're all curries, so it's all cancers. And different cancers are like different curries. I don't know if that's a good explanation or not, but you have to come to the level that the patient is. So if you're talking to a health professional, you probably wouldn't be talking about 100 different curries, which there probably are in your country. 100 different types of curry. There's dry curry, there's spicy curry, there's korma curry, there's whatever it is, tandoori, there's this, there's that. And so I would use that explanation. And every curry requires a different spice for the flavor. And it's the same. Every cancer has a different treatment. So your friend's cancer will be different from yours. His curry may have jeera in it. Your curry has no jeera, but you have garlic in yours. Do you understand? And you get them to try, you have to find a way. We have to be creative. It's too simple to say people don't understand. They do understand death. That's something they do understand. Okay, well, we feel embarrassed. You probably feel embarrassed talking about a curry. You think, oh, this is stupid. But actually, you feel awkward. It's hard breaking bad news. Being powerless. And I think particularly for doctors, that's very, very difficult, because if you're a surgeon and you know you can't cut it out, if you're an oncologist and you know there's no chemotherapy, if you're a radiotherapist and you know that this tumor does not respond to radiotherapy, you feel powerless. When I first came to India in 1984, I was a nurse. I wasn't doing palliative care then. I was a surgical nurse and a teacher. And I came on a holiday, but I wanted to visit the hospital because I was interested. I felt powerless. It really affected me. When I saw those patients, I wanted to do something. I thought, oh my God, this is terrible. This is terrible. There was no point just saying this is terrible. You have to do something. That wasn't my time. In 1988, I was inspired by somebody at a conference, and in 1989, the WHO, the World Health, asked me to come to India to do a needs assessment. I still felt powerless because all I was doing was recording the suffering and feeding it back to the WHO. But in 1990, I set up my own NGO, Cancer Relief India. And that gave me, I don't mean power, but it enabled me to do something. And even now, sometimes I see patients and I feel powerless. Yesterday we went to see a patient that was in ITU and shouldn't have been, in my opinion, the patient should have been at home. But I am just a nurse from England with an interest. I was powerless. The patient was receiving, in my opinion, inappropriate treatment for a dying person. There wasn't much we could do, but actually we did talk to the relatives and maybe things are going to change. But when we feel powerless, we want to run away. Not enough time. Is that a problem? Not enough time to break bad news? Is that a problem in your country? Or have you got plenty of time? Do you have enough time to have consultations with your patients? No. Okay. Approximately how much time would you have? Yes. Oh, that point of view. Okay. 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 Sure. Okay, so are you a social worker? Yeah. Do you have to break the bad news? So are you following up? So will the patient have already seen the doctor by the time they come to talk to you? You're a teacher. Okay. Right. Thank you. So in terms of time, I understand that. We have to create an illusion of time, and that's why it's important to sit down and shut the door and sit down, because one of the first things you have to do is to prepare the person mentally. And the very fact of sitting down and shutting the door, what's it doing? What does it do psychologically? Makes him more comfortable. What else is it preparing him for? It's preparing, oh, she's shutting the door. She's asking us to sit down. She's asking to see my relatives. Oh gosh, is this bad news? So actually you're not saying, oh, come on in. Yes, bring everybody in. It's all great. We're going to have a party. Your whole demeanour is serious. You can smile at them. You can be compassionate. The way you speak is important. But there's something about your demeanour, your body language, your behaviour, that is saying, this is serious. So hopefully for the most of you who are social workers, the doctor will have already seen the patient. Hopefully will have told the diagnosis. I'm not quite sure in your country what your role is. It's different from my country. So by the time a patient in my country sees a social worker, they will know the diagnosis. And the social worker is going to be helping with family issues, if there's young children involved, if this person lives on their own, if they're elderly, that sort of stuff. Okay, so it's important. The time issue is important. And do you say, I'm sorry, I only have 5 minutes. I have 5 minutes. Hurry, hurry. Or, we have 5 minutes. 5 minutes, and it's your time. Which is longer? 5 minutes standing up, or 5 minutes sitting down? But it's the same, standing or sitting, but the illusion is longer. And you need to give the person a time frame. We have 10 minutes. You don't say, I have only 5 minutes. You say, we've got 5 minutes. And I can see you again later on, but I have many patients to see today, but we have 5 minutes. I want to hear from you, as a patient, what are the things that you want to ask me? So you don't tell them anything. You find out what is the worry for the person. And if they know there's only 5 minutes, they'll come straight out of it. They may say, am I dying? You might say, if you don't know the answer to that, I don't know, but why are you asking? I haven't got your case notes. Why do you ask? I'm asking because if I'm dying, like our colleague at the back in the blue jumper said, she wants to travel around the world for 6 months. So if I'm dying, I want to get my daughter married. If I'm dying, I want to call my son back from America so I can see him. So you find out what's important for the patient. And we think we've got to give all this bad news. 99 times out of 100, the patient knows. And we're reminded of our vulnerability, because when people cry, how does it make you feel when a patient cries? How do you feel? How do you feel? The patient starts to cry in front of you. How do you feel? Or don't you feel anything? You say, oh, they're crying. Come on, cope up, cope up. Is that what you say? What do you say when somebody is crying? What do you do? What do you say? Don't say anything, you just watch them. You may try to console. You might just want to put your hand on their shoulder or their arm and just say, this must be really difficult for you.
You can also say that it's okay to cry.
It's okay to cry. It must be difficult. I've never been in that situation, so you need to help me understand. Not say, oh, I know what you're going through. You don't. Even if you've had breast cancer and the person's got breast cancer. You may want to reveal, you can say, I can imagine it must feel terrible. You must be worried about your family. So you're using your imagination and empathy. Not, come on, cope up. That's what I'd say to you, cope up if you failed your exams, because it's not the end of the world. Come on, get back, start studying, and come back and do the test next week and you'll probably pass. That's the sort of pat for that, but not when somebody is distressed. It's a gentle touch. But we feel uncomfortable most of the time, and it's understandable. So 10 steps. Preparation. Prepare yourself. When I am having to give bad news, I pray to God. Because even though I've been in this sort of work for over 30 years, it still goes to my heart. I still feel sad. I still think, oh hell, what am I going to say? I don't want to say the wrong thing. And I pray that God will just direct my words, that God will direct my head and my heart and my mouth. And I just center myself. I forget about, oh, how do I look? Is it going to be, what am I going to say? Blah, blah, blah. I just think only of the patient. What's it like being this patient? A young patient with a young family about to die. What's it like? Now, this is important. What does the patient know? Don't tell them anything. Tell me, have you seen the doctor? So what do you know about your illness? Great. They might say nothing. They say, I don't know anything. Right? So what do you do then? I don't know anything about it. This is important. What more do you want to know? So what do you know? I know nothing. Think, oh my God, I've got to tell them it's got a stage 4 carcinoma of the whatever that's responsive to this chemotherapy. No. What do you want to know? So have you told them anything yet? Have you said anything about their illness yet? No, you haven't. You've just prepared the room, sit yourself down, pull the curtains if you can get them. If you're in a ward and there's no curtains that you can pull around, go and get those mobile curtains and bring them around the bed. It's telling the patient somebody's saying something serious. Go and get a chair and sit down. It's preparing the patient mentally. That's what it means by preparation. Go and read the notes. Make sure you know what you're dealing with. What does the patient know? Simple. So I say to you, what do you know about, making a curry? You say nothing. Would you like to know about making a curry? I might say, no, I don't actually. I like Indian people to cook curry. I'd never make curry as good as you guys. I don't want to know. Or I might say, yes, I do want to know. Please teach me. Do you understand? What does the person want to know? They may not want to know everything or anything. Give a warning shot. Now, this is important. What do I mean by a warning shot? What do you think that means? Right. Now, part of your warning shot is you're sitting down. Your warning shot, you're thinking about your body language. You just say, yes, I've got news for you about your cancer. If I said that, what would you think about your cancer? What would you be thinking? You're the patient now. Use your imaginations. If I said, come in, let me tell you, I've got news about your cancer in this sort of thing. What would you think? Would it be good news or bad news? Oh, yes, thank God. Be good news. Actually, it's not a cancer, it's just a cyst. I know you were worried about having breast cancer, but actually, it's just a cyst. Right? Your whole body posture. Come in, Mrs. Patel. Please sit down. I've got the results of your tests from last week. What are you feeling? What they're going to say? I'm sorry, it's not as we had hoped. I had hoped it was going to be a cyst. But I'm sorry, it's more serious than that. That is called a warning shot. You still haven't said anything. You're preparing the person mentally for this very big, bad news. I know about time, but this is really important, Bob. Sorry. Okay, you're preparing them. Your face is serious. Your body language is serious. You're not speaking quickly. You're giving time. You pause. Just allow a space for the time. They probably will start to cry. They may start to cry. Normally, if it's a woman with a sari, she'll be like this. She's dignified. She may pull the sari over her head and use the pillow to start to wipe her tears. So you're preparing them. That's the warning shot. Now, this is before you've said anything. Allow denial. That's often the first response. I don't want to talk about it. I think you've got the diagnosis wrong. Let's go to another hospital. You just sit and listen to that, okay? Sometimes denial is a good defense mechanism. Explain if requested. So you can say, would you like me to explain? Some patients say, no, doctor, no. You just do what you have to do. My dad said when he had bowel cancer, you just do what you have to do. I don't want to know, I trust you. My mum, when she had bowel cancer, wanted to know everything. She wanted to know everything. Because my mother was medical. She was interested and she wanted to know. She wanted to be in control. So we are all different. What more do you want to know? And if you don't know, just say, look, actually, I'm not able to explain to you because I don't know your full history. Would you, now social workers, you can do this, nurses, you can, would you like me to ask your doctor to explain? No, I don't want to know. I don't want to know. Oh, yes, please. You give them the choice. Listen to their concerns. So, I'm sorry I've had to bring you this bad news. What are your worries at the moment? What's going through your head? What are your worries? So what might the worries be? Can I afford the treatment? Will I be separated from my family? Will I have pain? Where will I die? When will I die? What about my daughter's marriage? What about my son's graduation? Those may be the concerns. So you just listen to those. You listen. And you note them, because that's part of your overall care of the patient. Encourage a ventilation of feelings. Do you know what I mean by that? They could be really angry. It's just not fair. I went to Tata Memorial, they said nothing is wrong. And now you're finding this. Those doctors at Tata, they're terrible. Just allow it. It's a distress. Just let it out. They may be angry, they may cry, they may withdraw, but allow it. Don't tell them to cope up, just allow them to ventilate. And then you summarize, you say, right, well, we've got some treatment options. We can do this, we can do this. Unfortunately, your cancer has advanced, but we're going to be with you. We have excellent palliative care, and palliative care is an extension and is a branch of medicine that we use always in partnership with any treatment that we give, because 80% of your patients will need palliative care at diagnosis. For pain, for itch, for soreness of mouth, for constipation, for diarrhea, they're going to need palliative care. So we will not abandon you, because that's what people worry about. That when the doctor says there's nothing I can do, it means, oh my God, I've got nobody to help me. But here in Shillong, you've got support. You've got a brilliant, second to none palliative care team here. And I've travelled all over India, from north to south, from Kanyakumari to Kashmir. You have a brilliant, brilliant team. And I would be distressed to think that none of you would use your palliative care team when you have patients that clearly need it. And offer availability to talk to them. Preparation, know the facts before the meeting. Find out who the patient wants present. Now, I know our doctor colleague said, the relatives come in and they say, don't tell them. It's much better for the patient and the family if they're told together. But the patient is the one that should have the choice. All of you have said you want to know. And I would be saying to the relatives, look, it's going to be much easier for your father, your mother, your wife, your husband, if actually we work together as a team from now on. Because if I lie and I pretend to your loved one that everything is going to be all right, trust me, they know that it's not going to be all right. So you really, really need to think about it and, be careful about collusion. Be careful about a conspiracy of silence. Ensure privacy so that you won't be interrupted. Turn your phones off. So you can imagine you're just about to give bad news. And, hold on a minute. Yes. Let's go to Deja Vu. Yes. Sorry. What did you say about dying? You're worried about dying? Once you've lost that communication, you'll never get it again. that's what you want, keep using the mobile phone. If you're afraid of the patient, years ago, we didn't have mobile phones. There weren't any phones. Patients had the chance of having a proper consultation. Now there's a consultation with a dozen other things going on. So what you need to do is turn your phone off or on silent. Now, yes, if you're waiting for an emergency, you may have to look at it. Ask the patient. Otherwise, let them see you turn it off. You turning your phone off, what would that say? The patient is important, not you. The trouble with mobile phones is it makes us feel VVIPs. And in some conferences I go to, I've been to in the past, people like to leave their phone. In the early days, they liked to leave their phone. Not many people had mobile phones. They liked to leave their phone ringing as long as possible while they walked out of the lecture hall. You're laughing, it's true, isn't it? So they'd be sitting here, and the phone's going off, and I'm trying to teach. Slowly bring it out of the pocket. They get out, they walk out, or mobile phone. Use a VVIP, mobile phone. And it's ringing all the way to the back door, distracting my teaching and what's going on, because he thinks he's important. Mobile phones, they're common now. You don't need to impress anyone. They don't impress anybody unless you've got the biggest and best iPhone or something like that. You know, it's unimportant. You're not important anymore. It's just a means of communication.
Julie, the privacy is interrupted. Tea is getting cold and we can't warm it.
Good.
Please.
Tea time.
Tea time.
Prioritize.
And you come back.
I was just about to come on to prioritize, and I will leave it here so you need stools or chairs to sit on while you're having your tea. In privacy. Okay? We'll reconvene. know. What does the patient know? The patient will know something, won't they? How did this all start? So you allow them, well, I started having difficulty swallowing, or I noticed one morning in the shower, I felt a lump, or I noticed some discharge of bleeding. What does the patient, and let them tell their story. Why is that important? Why is it important? It's important because it helps you to know what the patient's understanding is. And you might say, so what did you think it was? And they think, I don't know, I didn't think anything. So you're starting to help them to adjust. It's very important. What does the patient know? How did it all start? Ask for a narrative of events by the patient. How did it all start? Would you like me to tell you what's happening? What does the patient want to know? What would you like to know? On my for me simply, I've got this very extensive schedule which started in Cochin to Trivandrum, up to Guwahati, Silchar, here, back to Guwahati, Dimnapur, Delhi, Rishikesh, Haridwar, Delhi, Shimla, Manda, somewhere else. I need personally to see it all. I do want to know what's happening. But when I first come to India, I say to the person, Shalini, who organizes all my travel, look, I'm coming into India on the 1st of February. I leave on the 28th of February. So when I'm in England, I don't care what they're doing to plan my trip. All they need to know is the day I arrive and the day I leave, and I said, you can do with me what you like. When I'm in India, I need to know where I'm going on what day and what day I'm teaching and what time I'm teaching. Do you understand? So there's levels of knowledge. I don't want to be overloaded with what's happening for 36 days while I'm in India and which train I'm getting, the 574312 Silchar to Kalka train. I don't want to know that. I don't need to know that. But I do want to know what day I'm supposed to be where. So what does the patient want to know? Would you like me to discuss this with you or with your family? Or would you like the family to be with you? And some patients will say, discuss it with my family, I don't want to know. And you could say, well, that's fine, but if at any time you do want to know what's going on, just let us know and we can talk you through. We talked earlier, giving the warning shot. So, I'm afraid it looks serious, but your body language is serious. You're sitting down. You've shut the door, you've drawn the curtains, your voice is serious, your body posture is serious. I'm afraid it looks serious. Allow the patient time. Don't say, I'm afraid it looks serious, but we can give you chemotherapy. I've been in touch with the surgeons and they can do surgery. What will happen is, first of all, you'll have chemotherapy to shrink your tumor, then you'll have surgery, then you'll have radiotherapy. It's too much. Just let it sink in. You will feel uncomfortable. Professionals don't like silence because you think you have to fill the space. Just let it sink in. Let it sink in. Allow a patient a pause. Allow denial. So denial is a defense mechanism and a way of coping. And it's very common, particularly at the beginning of a diagnosis. This can't be happening, it's not true, the doctor's got the wrong diagnosis, I want to go to another hospital, blah, blah, blah. I can't believe this is happening to me, I can't believe it's happening. So you have to allow them time for that. And, importantly, allow the patient to control the amount of information. The patient. Not the relatives, the patient. I am a control freak. Do you know what that is? A control freak? I'm a bit of a freak, but I like to be in control. I live on my own. I look after myself. I organise my own life. I like to know what's going on. I'm happy to share in teamwork, but if I'm required to do something, I want to know what's happening. So that makes me feel comfortable when I know what's happening. And I want to control the amount of information that I'm having. So I might want quite a lot of information. On the other hand, I might decide I don't want any. Explain, no, I don't understand, doctor, please can you tell me? And sometimes it might require a drawing or some way of describing it. Narrow the information gap step by step. Do not bombard them with information. Detail the time of the train, the number of the train, how many stops it's got, 49 stops and it's travelling at 25 kilometres an hour, is unimportant. That's not important. That just overloads the patient. Detail will not be remembered. But what will be remembered, do you think? It involves you. And I can tell you this from experience. Detail will not be remembered. But this is a session about communication. And this is absolutely true. But the way you explain and the way you speak to the patient and the relatives will be remembered by them until their dying day. So you have it in your mouth and in the way that you communicate to completely destroy a person or to build them up. How you do it is terribly, terribly, terribly important. The dissatisfied dead cannot noise abroad the negligence they've received, so they won't complain because they'll be dead. The relatives probably won't complain because they're too scared, but they'll never forget you. That brutal doctor, that brutal nurse, that brutal social worker. How do you want to live in your patients and your relatives' minds and hearts? When my father was diagnosed with cancer, he had cancer of the bowel and he'd been operated on. He had a lovely surgeon who'd operated on him before for an ulcer and everything was fine 15 years earlier. And when I went to the bed and looked, I was a nurse, and I just looked under the sheet and I saw that he hadn't got a colostomy. So I thought, oh, that's good. I made an assumption. So I said to my mum, well, he hasn't got a colostomy, so, maybe they opened him up and everything was fine. I was an oncology nurse, so that's what I thought. He took us in. Now, this story I'm telling you about was 1985, 24 years ago. And I can remember it as if it was yesterday. 34 years, isn't it? 34, goodness me, 34 years ago. And I can remember looking under the sheet, and I can remember, this is before any of you were born. and it seems an insignificant thing. So this wonderful doctor, his name was Dr. Chappell, took us into this little tiny office, which was a bit Indian, full of papers and files and books, and basically nowhere to sit. So there was an armchair, and my mum sat in the seat of the armchair, and I sat on the arm of the armchair, and the doctor sat on the desk, because there wasn't anywhere else to sit. I remember that 34 years ago. And so I said, I see you haven't done a colostomy. You know, Dad's going to be okay, isn't he? Isn't he? My dad's going to be all right, isn't he? He paused. He said, I'm sorry. We couldn't do a colostomy because his disease is too far advanced. I was a nurse, 30 years old, and I started to cry. The tears just started to drop. And my mother said, don't worry, my daughter is a nurse, she can cope. And you know what the doctor said? And I'll never forget. She's his daughter. She's not a nurse now. She's his daughter. He was beautiful. Well, the experience, although it was painful, was as good as it could be. And I just said, oh, what will happen? He won't be in pain, will he? My dad won't be in pain. No, he said, he'll have palliative care. We'll keep him comfortable. You can take him home. I've never forgotten it. It was compassion. My dad didn't want to know. I used to talk to my dad. I said, Dad, you know, anything you want to ask? No, I talked about going to heaven and all sorts of stuff. He never wanted to talk about it. My dad died at home with all of us around his bed. My mother initially had a very good surgeon. And then there was some young doctor who thought he was so clever. And my mum was doing well. You saw a picture of her yesterday. She died a few days after that picture was taken. She was doing well, and I was due to collect her on the Saturday, and some young house doctor, some resident doctor, thought he'd be very clever. He said, well, Mrs. Byrne, we won't be seeing you again because, you know, there's nothing more we can do. And when I went to collect my mother from the hospital, the day before she'd been dressed and sitting up in a chair, my mother was in the fetal position. In bed. Mom, I said, what are you doing? I'm taking you home. He destroyed her spiritually. And it took me weeks to build up that spirit again. Not to lie to her. She knew she was dying. My mum talked about it. She wasn't afraid. But the way he said it was, nothing more to be done. And you're on your own now. You're on your own. And that's why patients keep going for ICU and other things, because they feel as if they're on their own. So they'd rather have ICU than be on their own. So both my parents, both bowel cancer, and the way it was told. My mum died in 2001, and I still have the pain of that memory. That's 18 years ago. So trust me, patients will never, ever, and the relatives will never forget your behavior, ever. And that is a huge responsibility. And even in India, where your relatives and your patients are so brave and they don't complain, sometimes say, oh, the doctor was very unkind or the nurse was unkind. they remember forever. Forever. So you have a responsibility in how you behave. The detail will not be remembered, but how you give the detail will be remembered forever. And that is in your gift. That is your responsibility. How you break that news. So listen to the concerns. What are your main worries at the moment? What are your main worries? Simple question. It shows the patient that actually you're not interested in their cancer, you're interested in the effect of their cancer on them. That's the point. That is the point, particularly you social workers and nurses. It's immaterial about the cancer. There's nothing that you personally can do. You can't prescribe treatment. What you can do is support that patient. Allow space and time for the expression of feelings. Encourage the ventilation. It's a key phrase in terms of patient satisfaction with the interview because it conveys empathy. Empathy. That means you are entering into that suffering with somebody else. And then you need to summarize and plan, because often patients say, oh God, I can't remember what they said. So you make a plan. Summarize their concerns. So you're worried about your daughter's education. Your son is due to get married soon. You're worried, will you be well enough for that? You're worried about the cost of your treatment. Is that right? Is there any other worries? Well, yes, I have another son in Australia. He doesn't know. I need somebody to tell him because I can't tell him myself. Will you help me? Will the doctor tell him? Can we arrange a phone call or a Skype? Allow the patient to express their concerns. Write them down. Is there anything else? It shows you're taking them seriously. Their actual cancer or their actual diagnosis matters not one jot for you social workers and nurses. It's the effect that matters. Plan the treatment and foster realistic hope. Realistic. So the social worker up there who wanted to go away for 6 months, maybe that is realistic, but it might be more realistic to say 2 months. Now, I trust everybody was here yesterday, so they will remember. Offer availability. Most patients need further explanation, and they may benefit from a family meeting. Check it out. Never assume. To assume makes an ass of you and me. Just because one patient reacted in one way, another patient will not act in the same way. So ways that you all can help. Find out what the patient wants to know. Say that you're unable to give information, if you're a nurse and a social worker, but would they, the patient, like you to inform the doctor to come and talk so that you can be like a go-between? Listen to their concerns and tell the doctor. So the oncologist may be writing up some big expensive treatment and want to send them to Tata Memorial Hospital. Actually, they can't afford it. But they don't want to tell the doctor that they can't afford it. But they might have told you that they can't afford it. So you have to be the patient's voice and say, you know, I know they said yes, they would go to Tata, but actually it means them selling everything. They have a son who is at university, and if they go to Tata for treatment, their son will have to stop his training, and he's in the middle of training to become a doctor. And the father wants to spend the last of his money on his son. So you have to be the voice for the patient, a voice for the voiceless. Allow them to express their fears. So use your imagination. Imagine your doctor knows. Would you want to know? So most of you said yes, right? Or would you want your family to know and the physician to protect you? So does anybody now, having heard what we've heard, decided that they don't want to know? Would you all like to know your diagnosis? Okay. So, now, not everybody is the same. So now that you know that that's something you would like, what are you going to offer to your patients? Yes.
From what? Further information or what?
And protect you means you.
Yeah,
Would
you
family
like
to
your
know?
family to
And,
know
to
and for
protect you.
them
So
and your physician?
would you rather I told you, or would you rather that I told the family and the doctor told the family so that we could protect you from the truth? That's what I mean.
I wouldn't want that.
You don't want to be protected. Anybody want to
No,
be protected?
protection up to what? Can there be some clarifications on what protection would be
Protection,
beneficial?
what I mean, it protects me because I don't have to tell the patient. Or it protects, in a sense, it protects you. Well, do you want to be protected in the sense that you don't want to know your diagnosis and you want your family members to take over? And my dad wanted that. My mum didn't. Very different. So, I think we need to say we have to be honest with the patients. The trouble is, I know this happens, the relatives come in and say, don't tell them, tell me. We wouldn't do that if you were pregnant, would you? The husband wouldn't come in and say, don't tell my wife she's pregnant.
Or would the wife say, don't tell my husband I'm pregnant?
Well, she might say to the husband, they go to the gynecologist and say, ask the husband to wait outside. You're pregnant. Do you want your husband to know? I mean, seriously. We have to think about it because our non-verbal communication of getting the patient and talking only to the relatives, if you're giving good news, you tell it to everybody. So it has to be bad news if you're separating people. Has to be. I know it's meant in love. I truly understand that. But I have seen many, many, many hundreds of people dying in an isolated way because the patient protects the family and the family protects the patient. And the two of them are going parallel, but they're not able to hug and embrace because they feel if they hug and embrace and talk about intimate things, they'll start to cry. And at the moment there's a big show. Okay, Papa, everything is fine. No problem. It's hard for the patients. It's a very lonely journey, and we mustn't make it more lonely. Or do you want the physician to protect you and keep the truth from you and lie to you in order to give you false hope? Would you like false hope? Because when the realization comes, sometimes people are very angry. So the lady in the blue who wanted to go, I'm sorry I don't know your name, I feel very bad about it. I think she's having a little thought or a ponder or looking at the phone, and that's okay. But anyway, she said she wanted to the last 6 months to travel around the world. But actually, if we don't tell her the truth, she doesn't have the opportunity to do that. So imagination, where the time comes, where would you wish to live your final days? Who'd like to die in the ICU? Anybody, any takers? Now come on, I went to an ICU yesterday, it was beautiful. I was really impressed. Sometimes your hospital wards are absolutely awful. They don't even have sheets on the bed. I must say that the patient we saw yesterday looked very comfortable, didn't she? She was well cared for. Nice dark green sheets. I thought they were great, actually. She was sitting up. She had tubes here and there. But it was clean. It was nice. Relatives were outside. Not too many relatives. So who'd like to die there? Please, can you get off your phone? If you want to use the phone, you're welcome to use it outside. If you want to text and things, I don't mind. But no talking. Because it's not fair on your colleagues around you. Right, and if this is boring you, get outside and go and have a walk. Right, so ICU. So we need to think about it. So nobody wants to die in ICU, are you sure?
The husband say that the patient wanted to come back to ICU.
Finish the story. Finish the story. That's what he said.
Yeah.
But it then transpires that later on, she said she would come back to protect the patients, to protect the relatives.
So they were feeling helpless. To relieve them of that, she said, okay, we can go back to ICU. But she is the person who actually wanted to go home from the ICU. She had insisted and gone home when she saw that everybody around her was getting flustered and feeling inadequate and what to do. So then she said, let's go back
I'll
to
go
ICU.
back. She didn't want to. So we need to think of a way of empowering the families to help them cope. We're lucky. I'm lucky. I'm like a doula. I'm like a midwife into the next life. It's something I love doing because it's a skill that I've got. Okay, so would you like to die at home with your family? Sorry. Yeah? Anybody not want to die at home with their family? Me. I don't have a family. Right. So I'm on my own. I live on my own.
We are your family.
That's why I want to come back to India to die. No, you think I'm joking. I'm serious. I'm very serious. I'm looking for carers as I come around India. I think, oh, yes, I'd like them to look after me. Oh, I don't want to go there.
You come to Shillong.
I'll come to Shillong. I'll come to Shillong in the summer and I'll go down to Kerala in the winter. No what? Okay. Yeah. It's the cold I don't like, but we'll see. Anyway, there might be nobody that wants to look after me. So there we go. So on your home in a hospital ward. Who'd like to die in a hospital ward? Well, actually, I would. Because I'm a busybody. I'm bossy. I'm a busybody. And I'd probably like to be nursing until I die. If I was physically able to do things, I'd want to be with the other patients. I think, oh, that patient needs a drink, I'll go and give them a drink. Because I wouldn't have family, so the patients, my fellow patients, would be sort of become my family. And it would give me a sense of purpose and meaning in my life. Do you remember we talked about that yesterday, spirituality? I'd still be thinking, I can do something to help other people. So I probably wouldn't mind a hospital ward, to be honest with you. I wouldn't want to have to go to the bathroom in public, in bed, on a bedpan, in front of other people with no screens. I wouldn't particularly want that because I'm quite private about those things. But from the point of view of being in a hospital ward, so long as the nurses were kind and the place was clean, I wouldn't mind. On your own at home, which is what I would have to do, but I probably wouldn't want that. But would anybody else like to be on their own at home? Okay. Nursing home. Yeah. That might do for me, actually, nursing home, so long as I didn't have to sit in one of those awful chairs and be tied down. As long as I was allowed to live the end of my life in a proper way. Hospice. Some of the hospices are really lovely. Nice fountains in the gardens, clean, do what you want. So I probably wouldn't mind that. Now, I've given you another opportunity. Are you sure you don't want to die in ICU? Got a super doctor. Look, one of the top ICU specialists in India. It's a big insult to him that you don't want to die in his unit. It's a big insult. He will be very, very upset. He knows all your names, and he's going to be examining you when your exams come. And you don't want to die in ICU to please him. If you don't want that, should we be a voice for our patients? And the skill is talking to the relatives, not just saying, oh, the relatives say this. The skill is spending that time to explain what happens. Do you want to say something, Bob?
See, when we say, are you sure you don't want to die in the ICU? What would you like to do? Why would ultimately relations want to take the patient to the ICU? Or why would the patient, there are patients who are afraid, say patients with COPD, severe status asthmaticus, they know how bad it can be in that terminal point. Will there be somebody to give them comfort care in that they are not going to feel the sensation of drowning in their secretions or not being able to breathe? If somebody can provide that, then they would not want to, they know they will die. In an ICU, we'll give all the medicines and ultimately he'll die. But if we are going to give them comfort care in their home, then he will die, definitely, but he will gradually go into a sleep and not feel that difficulty. The difficulty of breathing will remain, that saturation will keep falling. These things we can do. We can give that comfort care, sedation. If he knows that that can be provided, he will not want to come to the ICU. But if he feels that in the end, he will be drowning, he can't breathe and nobody handling, nobody doing anything. In our ICU also, we try to give comfort care at that point of time. So ultimately, if this comfort care could be provided there, then he would not want to die in an ICU. So that category of patient. So each patient has his, whether the pain, will anybody respond when that pain starts? We had one patient, a big carotid tumor. So the only thing they were worried about was, they were told that one day it will rupture. So the only reason they would like to come to a hospital or an ICU is that, what will I do when so much blood comes? Will it be painful? If they know it is going to be painless, they are not worried, number one, for the pain. But doctor, so much blood, what will we do when it's, you are telling it will rupture. I said, well, nothing will squirt out. We can prepare you by keeping multiple rolls of cotton.
Dark cotton.
And the dark cloth, so that it doesn't look bright red blood so much. And you put it there, don't wait for it to fill up. So that when you lift it, again everything starts dripping like a Dracula or a vampire. And you just pick it up when it is half full, half soaked, and keep 2 big buckets. Just keep putting them, and you call us, we will come until that time, you just adequate number of these are there. And you keep putting them into the bucket, so that one fills, you use the other one, and we will reach by the time. If he bleeds out before we reach, he will have simply become drowsy, gone to sleep, no pain. And you don't have the floor, everything awash with blood, then they will not want to go to the ICU. So each patient's requirements, you have to think according to that diagnosis, and what can we do to make it comfortable. So these things, again, we can explain to you, so that you can also interface. See, social workers, we have Bashi Shah, etc. They also work with us. So these are supports. This is not a medical treatment. You have to understand, this is not a medical treatment. But when she was taking out the maggots, she had never seen it before. But it was not medical treatment. It was simply a relief. It was a comfort care. So there are things which you can increase your skills and capabilities, but all of those will help to keep those patients feel that they don't need to go to the ICU, because they wanted to go to the ICU only because they felt there was a lacunae. This patient she's talking about is today going to go back home. They only needed an assurance that a doctor will respond when things go wrong. Then they specifically asked, if it happens at 12 o'clock at night, we'll come. Okay? So this is how it goes. Okay?
Thank you. So listen to what the patient's fears are, and we need to help people to understand. Now the thing is, the good thing was yesterday in ICU, The lady was not intubated. It's agony. It's horrible. I'm sure it doesn't happen here, but in some ICUs, they tie people down with their fingers. Hands up who'd like to be tied down. If not, why not? And is it ethical to subject your patients to it without their permission? So 4 cardinal principles: patient autonomy, respect for the patient as a person, beneficence, do good, non-maleficence, minimize harm, and justice, the fair use of resources. This is a true story. 81-year-old lady, stroke, spinal fracture, hospital for 3 weeks, cardiopulmonary arrest, ventilated, able to breathe alone, and the ventilator was removed. This gentleman was, Anil Kumar, was a doctor. His mother was seen by 2 intensivists, spine surgeon, general surgeon, cardiologist, neurologist, dermatologist, gastroenterologist, intensive care specialist. Where was the nurse? Where was the social worker? There wasn't one. All these people getting rich because they all had, they thought, something to help them get more money into their pockets, and an anaesthetist. So the family with the doctors decided not to re-intubate her, and written permission was given for that. However, the next day they came in and found her tied to the bed, an 81-year-old lady who's had a stroke, who cannot move, tied to the bed, dying with a horrible, hard tube in her throat. And her only comfort, the pip, 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 pip. That's the ventilator. That's her comfort, because her hands are tied. She's got an itchy nose, but she can't scratch. Use your imaginations. Would you want your family members like that? Would you want to be like that? We have to be a voice for the voiceless. The families were distressed. The patient couldn't respond because she's been paralyzed by an injection, so that she doesn't fight the ventilator. Terrible. This is barbaric. Absolutely barbaric. The family was advised to sign a discharge against medical advice. That's a terrible thing to do, because it makes people feel guilty, because they think that ICU is the best place. Mother was taken home comatose, intubated, on oxygen, and died within 2 hours, surrounded by her family at home. Should never have been in ICU. Never, never, never. Not only that, but what did it cost? Not only emotionally and spiritually and physically, but what did it cost financially? The only people getting rich are the doctors and the hospital. Would you have wanted this for your mother? There may be times when we're powerless to prevent injustice, but there must be never a time when we fail to protest. And this lady was involved with the concentration camps in Germany. So he wrote an article in a journal, which he's a cardiologist. I'll give you the reference. My family and I are writing this to improve conditions in India, a final gift to our mother and our motherland. It's time to take action now, or others will undergo a similar ordeal. Every hospital should have an ethics committee, which includes physicians, nurses, social workers, and someone non-medical from the community, such as a priest or a well-respected volunteer. This wasn't written by a British or American, it's written by an Indian. And the sad thing is, it was written in 2005. 2005, and still, 14 years later, we're still doing these things. So this is my dear friend Sadie. And she died in the intensive care unit, but we were fortunate. We were very, very fortunate in that the intensive care unit was very dynamic, and actually what we did was we brought in the bed cover that her mother made when she was 10 years old. This little girl was a 10-year-old girl. And we brought in her favourite shawl. We brought in her favourite cushions. This actually was my pillow because it was made of pure cotton, so it didn't sweat. Here she is ventilated with photographs on the bed, the hand of her mum just there, comforting. Beautiful. This was just last year this happened. And this was after she was extubated. We'd been asked for the organs, but actually she didn't die in time to take the organs. She died 36 hours after she was extubated. And she just died peacefully. And we put little lights around her bed in ICU. You can see all the tubes here. Lights around the bed. This little bird here. I'd recorded some bird song on my phone, some bird song first thing in the morning, and I felt Sadie's going to die today. I just had the feeling. And so I hung this phone up above her bed in a little case, and she could hear the birds. It was beautiful. And then we had some gentle music that she really loved. And in the background was the bip, bip, bip. That was still there. That was still there. And there's a picture here of Sadie when she was younger, having got her master's degree. So very, very beautiful, very beautiful. And this is her little boys' school class. So when the nurses came, and this is why it's important, nurses and social workers, for you to know about the family and how we can make things better. So you'd look and say, oh gosh, who's this? Well, this was Sadie when she was younger. And here was Sadie when she was a bit older. very, very beautiful person. And her little boy is here somewhere. Oh, how old is he? What's his name? His name's Joseph. He's 8 years old. He was left an orphan. No dad, and his mum died. And I'm the adopted granny. So that's how it could be. But what do? We keep people out of ICU when people need to be there. Listen, sit and listen. Compassionate communication is the key to compassionate care. So how do you sleep at night? Remember I told you this story, and you can have hope still. You need to ask, it says sleep nurses, but social workers, how do you sleep? Find out what the patient wants. My mum wanted to see her granddaughter married, and that was her hope, and it happened. So the importance of communication. I did some work down in Trivandrum, and I didn't show you this picture yesterday, did I? Did I show you this yesterday? No? Okay. So, there was a group like you, and I was teaching in the afternoon, and nobody knew me, so that was fantastic. So I prepared my room at lunchtime, and I wanted to make it as unfriendly and as patient-realistic as possible. Patient-realistic in some government hospitals, not this one, but some of them. So I divided the group up, kept them outside, wrote silence on the door and keep out. These are all people that can read English, because they're doctors and nurses and social workers. So they start coming in. I said, can't you read? It says silence, keep out. Keep out. And stop making such a noise. Shut the door. Who is this person coming to teach us? Who is it? Who is that woman? It's horrible. Oh my God, we have her for 3 hours this afternoon. She's teaching us. Terrible. So the first one came in, and I went to the door and said, come on, you, get in here. Get in, hurry up. I sat down. I said, right, what's your name? Where'd you come from? Are you a nurse, a doctor, a social worker? Stand over there. Next one, I got that person to open the door. Open the door. The person opened the door. I stood up. Namaste. My name is Gilly Byrne. I'm a nurse from the UK. Please, sit down. What is your name? Where do you come from? Are you a nurse, a doctor, or a social worker? Thank you. Would you like to sit over there? So I did it, right? And this was their reaction, because they still didn't know what was going on. Particularly this lot. So, with no welcome, no namaste, no nothing, just get in here. Often people don't say a word. I was in a cafe the other day in India. Somebody had made a beautiful juice drink, and the cafe owner took it over and he gave it to the man. Man never said thank you. He drank it. Lovely juice. Went to pay the bill. No communication at all. Not, ooh, thank you, that was delicious. Nothing. Maybe we're talking too much on mobile phones and not enough to each other. So what did they say? This is my writing. This is what they said. I just said, tell me the words you feel. Upset, needful, not sure, uncertain, no hope, low self-esteem, inhumane, that's me, alienated. This woman has a big ego. Who does she think she is? Doctor? Anxious, terrible fear, strange, or was this a stranger? Uncomfortable, unsatisfied, angry, felt unwelcome, hostile, annoyed, felt very bad. What type of person is this? So instead of putting a doctor or a social worker or a nurse, imagine that's a patient. And they come in and you speak to them like that. Those are the thoughts that go through their heads. They won't say anything to you. Do you think that the group would want to talk to me for 2 hours? Do you think we'd have a good relationship in order to teach for 2 hours more? You'd be absolutely silent, probably walk out, because you can do that sort of stuff in India now. Okay. So, a simple interaction like namaste restores the power balance. It's about building a relationship of trust and rapport, and these things are important if you want to succeed. Make your patient feel like a VIP. The group said the greeting of namaste was not normally used in the clinical setting unless the person was very important. Well, Gandhiji said a patient is the most important person in the hospital. If Mr. Modi came in, what would you do? Would you stand up or would you carry on sitting there looking at your phones, talking on your phones? If Mr. Modi walked in now, what would you do? You stand up? Exactly. Would you smile? Would you be... You'd be this, wouldn't you? Probably. Sir. I don't expect you to touch your patient's feet, but it takes no time. It's just a second to say, Namaste, my name is Gilly. Namaste, my name is Sandra. Namaste, my name is Bashisha. Namaste, my name is Professor Rajgopal. Or Professor Bhattacharya, Professor whoever. Namaste. It takes no time, but it changes the relationship. It changes the relationship. Remember Gandhiji. So the other side said they didn't have so many feelings because they felt great. The ones that had the welcome, Wanakam, and that was in Tamil Nadu, I must have showed this, they felt honoured by the namaste. They felt honoured. The God within me bows to the God within you, so I'm recognising there is a God within you. Do you know what the difference is between God and a doctor? God doesn't think he's a doctor. Get that? Sometimes doctors think they're gods.
But God is a doctor because we pray to God to make us well.
Exactly. So, namaste, they felt privileged, they had high self-esteem, comfortable, respected, welcome, dignity, familiar, no tension. Now these were medical people. Why on earth they felt afraid of a nurse from England, I do not know. So if a doctor is afraid of a nurse, how much more afraid will a patient be of a doctor that they don't know, who treats them like this? So we need to think about this. Time, people say, haven't got time to sit down. It's the same. 5 minutes sitting, 5 minutes standing is still 5 minutes. Oh, that's it. That's it. Finished. Done.
Thank you.